So I'm going to talk about something completely different. So I'm hoping my slides will be all right. They look a bit different and they haven't got the logo on, but let's hope that everything will be there. So I am a consultant dermatologist and have been for a long time. I've been a trustee of the association for 15 years now. And I've been involved in service redesign, which is about trying to ensure that patients get seen by the right person in the right place at the right time, which is what great words that I heard from you that were music to my ears. And I'm speaking to you today as clinical lead for the NHS Outpatient Recovery and Transformation Programme. And as part of that work, I'm going to update you on some of the new pathways of care and what you should be able to expect as patients. I was here last year when I spoke about this. So for some of you, I apologise if it's repetition, but I am going to revisit some of the pathways that I spoke about last time. It matters hugely, doesn't it? And every time I go to important meetings, I think about some of the conversations that go on at those meetings, and the patient is really not mentioned at all. And we have to get the patient right back in the centre of all of this. And I think these are some quotes that I actually received from the association ahead of last year's meeting, and I think they're incredibly powerful. What they tell us is that people with psoriasis have done very badly in terms of access to care over the last few years. And this has been made much worse as a result of the COVID pandemic. And the reason for that is that dermatologists have been encouraged to focus on what's called the 2-week wait skin cancer pathway, and I'll come back to that. And we have to redress the balance, and that's what I'm trying to bang on about all the time. So for those of you who don't know, about 50% of a dermatologist's specialist workload is inflammatory conditions like eczema, psoriasis and acne, and the other 50% is skin lesion diagnosis and management, and in particular the management of skin cancer. And I remember many years ago talking to Catherine Smith about how much do you think of your caseload is skin lesions? And I think we said about 30% at the time, and that must have been 20 years ago. And we're now looking at over half of our caseload is this. So we've got to redesign things so that this balance is right for people with inflammatory skin conditions, and make sure that everybody gets seen at the right time. It's not fair that people sent on a 2-week wait pathway do better than people with long-term inflammatory skin conditions, particularly since we know that large numbers of people that come on that rapid access pathway actually have what we call non-relevant or benign lesions. So appointments are being cancelled to see people with something that is innocent. Appointments are being cancelled for people with psoriasis that really need to be seen face to face. So we've got to get things right. Where am I pointing? Okay. So the dermatology workstream started in 2020. I'm so excited to see Emma. I have never seen her except on a Teams meeting. So Emma LaRue was my primary care colleague, and we worked together brilliantly. I mean, she was just absolutely brilliant to provide the primary care perspective to this project. And we worked together, I think, for maybe 18 months, and then Emma stopped and I've carried on. But what I want to make clear is that the work that we've done everybody has been involved. This is not Julia Schofield and Emma LaRue deciding what needs to happen for patients. This is actually specialist organisations, people with lived experience. Everybody has been involved in developing these resources. And we've completed a lot of work now, and this is on something called NHS Futures, our guidance documents around what to expect in terms of patient pathways. We've developed a lot of new pathways, and we've got a lot of this stuff is also on the NHS England website as well. So last year, I spoke to you. This is one of the slides I've taken from last year. I make no apology in repeating the content of some of that presentation, because for those of you that didn't hear that presentation, you do need to be aware of these initiatives that are now up and running and are 12 months further down the line and implemented in quite a lot of centres around the country. So let's talk about referral optimisation first. This is really important for people with psoriasis. What we have done is we have suggested a completely new approach to accessing dermatology services. So basically, historically, if you had psoriasis and you needed to be seen, Emma's already said you try the treatment for a few weeks, it doesn't work, it's difficult. As a GP, she would refer you to see us. We would look at a referral letter and we would code it as urgent or routine. So that wasn't very good because it didn't prioritise the people who needed to be seen quickly. So what we've done is we've actually changed the front door access to dermatology services now. And the idea is that people will access care through something called specialist advice and guidance. So going back to Emma sitting in her surgery, she sees a patient, she gives some treatment, they haven't responded, she wants them to be referred in. She would use specialist advice and guidance, which is a new system that enables primary and secondary care to talk to each other. She would send in some pictures and tell us about you, and then we would offer some advice and guidance about management ahead of you attending for your appointment, and the appointment would be appropriately prioritised. So if she said to me, the DLQI, the patient's impact on quality of life is massive, they're off work, they're covered in psoriasis, I'm not managing to get this under control, they desperately need phototherapy, we could book directly potentially to phototherapy. So this is really transforming access to services, but it needs images, and I'm going to come back to the image story in a minute. So the traditional pathway I've already explained. So this is a 46-year-old teaching assistant, got psoriasis, and she's developed an acute flare. Her creams haven't worked. She's been backwards and forwards to primary care clinicians. She's no better. She's been referred. And historically, as I say, she would wait ages. We would not necessarily prioritise appropriately. And her appointment might well be cancelled to see a 2-week wait referral in order that we can meet our targets. And then after she's been seen, she may well join a phototherapy waiting list. So this is all terrible. So we need to make it better. So the idea is, as I say, that there is an interaction between the primary and the secondary care clinicians, which is supported by images and detailed history. The primary care clinician ticks the relevant box to convert that to a referral if we believe the patient needs to be seen, and the patient can be seen urgently as appropriate in the clinic or even booked directly to the phototherapy clinic in order to start straight away. We've developed some resources with the support of the patient organisations, and this is a template that's sitting on the NHS Futures website, which is an explanation of how this system works, and we're very grateful for the involvement of the patient groups to help us with this. Now, this should be available. 12 months ago, we had a few innovators and it was starting, but I think we've got around 85 to 90% of trusts are now using specialist advice and guidance. And the work plan that we do now in our departments is such that we will have a consultant who's on a hot week who will be reviewing these advice and guidance requests. So you should all be expected. And if your GP, if you desperately want to see, get a secondary care referral, you need to say to your GP, is it possible for you to ask for some help through the specialist advice and guidance? Here are some pictures of my skin condition, and that's available to you all. Okay, what about video consultations, remote consultations? So I think it's really important. Emma and I fought really, really hard to retain face-to-face consultations for people with inflammatory skin disease. When we started out on the programme, we were charged with getting 25% of all dermatology activity as remote or video or telephone consultations. We thought this was unacceptable. We felt that most people with an inflammatory skin disease, particularly a long-term condition such as psoriasis or eczema, required a face-to-face interaction for the first consultation in order to develop a relationship and be able to share how they felt, so that that holistic approach that Emma stressed so beautifully in her presentation could be taken forward also by the specialists. So where we got to, and actually what was really helpful was that the Psoriasis Association had done a piece of work during the COVID pandemic, asking members what they thought about telephone or video consultations. And it was really interesting that actually most people felt that that was most appropriate for people who were stable, possibly on long-term medication, or those people who had had a first interaction and then it was a follow-up. So there is a place for remote consultations, video consultations, but we need to be careful about how we use those. It's largely a visual specialty as well, and Emma mentioned she may be referring because she's not sure of the diagnosis. I can't make a diagnosis on a telephone call. I actually need to see the patient. And in fact, it's quite difficult to make a diagnosis on a video consultation because I'd quite like to look at the three-dimensional nature of the rash. Emma looks completely different three-dimensionally than she did two-dimensionally on those Teams meetings for all that while. It's absolutely striking the difference between a 2D and a 3D approach. And you should have choice. You patients should have choice. You should all be able to have a face-to-face consultation if that is what you want. A lot of things to think about. Because of time, I won't go through all of this, but there are some absolute no-nos of when you wouldn't do a video consultation. If you had genital psoriasis, I'm not going to ask you to take your underclothes off on that sort of, I want you to have privacy, dignity, this is not appropriate. So the type of skin problem that you've got is also completely relevant. And there's more detail on the slides. So we've got some best practice guidance on that, and remote consultations will be offered to you, but you need to make up your mind whether or not you think they'll work for you. What about personalised follow-up? So this is called patient-initiated follow-up. And I have to say, when Emma and I were first asked to talk about PIFU, Emma's reaction was, that's nothing to do with me, that's secondary care, over to you, Julia. But actually, what she did stress is that patient-initiated follow-up does have advantages for primary care healthcare professionals, because if patients can re-access the service as and when they need it, it's less likely that they're going to be phoning up the GP and asking them to expedite or get appointments. So patient-initiated follow-up is something that many of us have been doing for very, very many years. We've called it an open access follow-up, but it didn't work. Well, it did work. It worked for those people who shouted loudest. So if you actually knew how to navigate the system and pushed, you could re-access care when you needed it. But there would be lots of patients who struggled to re-access services if their skin condition flared on an open access appointment. And the idea is that PIFU, or patient-initiated follow-up, the idea of this is that you can re-access services as and when necessary. Lots of different names that it used to be called, but we have now formalised it as patient-initiated follow-up. So what happens is you have a negotiation with your specialist at the time of an appointment. If your condition is well controlled, then the consultant may say to you, well, shall we arrange a patient-initiated follow-up appointment whereby you can contact us if you need help in the future, if your skin condition flares. Initially, we were told we could only have PIFU for 3 or 6 months. It's a complete waste of time for people with psoriasis because their condition may flare in 12 months, 2 years, 5 years. So we've managed to negotiate that patient-initiated follow-up should be available to all of you for up to 5 years. And we have it on our system for 5 years. You should be given a telephone number in order to re-access the service, and there will be different models of how you re-access care. So this is available, and about 80% of departments are now using it. I'm ashamed to say that in Lincolnshire, where I am a consultant, it's not well developed. And if you go onto a PIFU pathway in Lincolnshire, unfortunately, you go to a centralised number, and often you currently are not re-accessing care well. So we've had it in place for 12 months. We're about to review it. We've had lots of concerns from patients, and so we need to make it better. It was set up as a centralised system, and PIFU works much better if the dermatology teams are involved in setting it up within their departments. Okay, now this matters to all of you. This is our clinical prioritisation document, our recovery document which we've been working on, and I think probably was not ready last year. And this is about managing people who have been on elective or routine waiting lists for a long time. And I've explained the backdrop to why that has happened. Now, what we know is that there will be some people on those waiting lists who desperately need to be seen, who've got terrible problems with their skin. Equally, there may well be people on the waiting list who no longer need to be seen. So we have developed a clinical prioritization document where we give guidance to systems on how to validate and to manage their long waiting lists. And the reason I'm happy to be here to be mentioning it to you, because you may well get a phone call. Many of you, if you've been waiting a long time to be seen, you may get a phone call which will involve a discussion with you about the severity of your symptoms and also about whether or not you need still to be seen. And some of the preliminary work that we have done has identified that between 20 and 30% of people actually, when we go through a straightforward validation process without involving clinicians, actually no longer need to be seen. And that's important because we don't want to be sending those people appointments and them not come along when actually we've got lots of people that do need to be seen. So you may get called and you may get asked to send in some pictures in order that we can then decide how to prioritise things. So basically, you may get called by the hospital, say, do you still want to be seen? How bad are you? How much is this in your condition interfering with your life? Have you been to see the GP a lot during the last little while, etc. Though that information will then be given to a specialist clinician who will then review that information, the initial referral with some images, and then try to prioritise and provide advice ahead of an appointment. And the images are key here in order that we can try to assess and prioritise appropriately into either an urgent or a routine capacity. And that brings me on to teledermatology, and I'm going to very briefly mention artificial intelligence because I'm conscious that that's been in the paper a lot lately. So Emma and I inherited the first piece of guidance documentation we inherited in 2020 was a teledermatology roadmap. Both of us at our appointment were told that that was a done and dusted document and we wouldn't be looking at it again. It became very quickly out of date, and we have recently revisited it and thought about how it could be better, because the role and importance of images to support dermatology activity, and in particular this prioritisation activity, has become much clearer and much more important over the last little while. So we need high quality images for all of our models, new models of care. We've had real pushback from general practitioners and primary care. They don't have time to take the pictures, so we're actually looking at new models and new ways of care to get those images, probably from community diagnostic centres. Lots of challenges for teledermatology. Some patients send in brilliant photographs, and at meetings that I'm at, there'll be a bunch of people saying, yes, patients can send in photos, their cameras are brilliant, and then there'll be a bunch of people saying the photos are terrible. So it's a mixed, there's a mixed approach, attitude to all of this. But there's one thing for sure, if we get poor images, that is double activity. And we reviewed some of our images coming into the Lincolnshire A&G hub, and about 30% of patients, we couldn't make a diagnosis or management plan, so those patients had to be seen as well, and they'd had that advice and guidance activity looked at. So you'll hear a lot about image-taking hubs being developed in community diagnostic centres, of which there are about 130 around the country. What about artificial intelligence? I'm just going to mention this very briefly. So artificial intelligence is right at the top of the political agenda, and the Secretary of State and the Prime Minister are very keen to push ahead with the use of artificial intelligence as an innovative approach to helping solve the problems of NHS waiting lists. And for dermatology, that is particularly relevant in skin lesion diagnosis and management. And the key area where there are some pilot sites running is actually to exclude benign or non-relevant skin lesions and avoid people having to come to hospital to be seen, but more importantly, avoid any doctor having to look at those images by the use of an artificial intelligence tool. The data suggest, and it is subject to a meta-evaluation which will be published at the end of the year, the data suggests that around 20% of all of our 2-week wait activity could probably be looked at by an AI tool and excluded. So it's not going to solve all the problems for us, but it may help. Now, I know Catherine Smith has done they've done a lot of work, her team, about looking at artificial intelligence in inflammatory skin diseases, and she may well mention it later, but my understanding is that we're a long way down the line. We're not going to be looking at people with psoriasis with AI tools. I think we're still going to be seeing you face to face, but those tools may well help in due course in terms of assessing responses to treatment and in the follow-up situation. So watch this space. Finally, I just want to make a mention about equality of access to services, because the last piece of work that we have done and published is a Pathways Redesign Consideration document. There's already huge inequity of access to services for people with skin conditions, and I've already alluded to those in terms of this mismatch between 2-week wait and people with long-term conditions. There's a huge mismatch in terms of equity of access for people with richness of skin tones, for people who need psychological support, and we recognise all of those. And what we've got to be careful about is that by introducing these new pathways, we don't actually make things worse. And I've already spoken about teledermatology, and there is the potential that actually we could make things worse rather than better. And we could exclude swathes of the population who are not digitally literate, and we need to be well aware of that. So we've done a Pathways Reconsideration Guidance document that looks at mitigations that you might need to put in place to avoid increasing inequity of access to services. And it looks at, as I say, it looks at all of those mitigations. So in summary, that's a whistle-stop tour of the work that we've been doing. Apologies to any of you that had heard some of that last year, but I did want to update that those pathways that I spoke about that were in their infancy 12 months ago are now well established around the country. We've got to do better. And Emma and I and the team at NHS England in the Outpatient Transformation and Recovery are working hard on your behalf to ensure that people with inflammatory skin diseases get seen in the right place, at the right time, first time, and 20 years ago, Nick Evans and I worked at Action on Dermatology, and it was right person, right place, right time. And I think we still need to be working towards that. And I hope that you will feel that we are on your side in trying to make things better with this work that we're doing. Thank you very much.